Hello, my name is Senia Del Pozo, and today I will be presenting a quality improvement project entitled An Educational Module on the Utilization of Haloperidol as a Pharmacological Complement for Postoperative Nausea and Vomiting Prophylaxis in Adult Surgical Patients. The learning objectives for this quality improvement project are to describe postoperative nausea and vomiting risk factors, discuss mechanism of action of haloperidol, understand recently studied antiemetics available for PONV prophylaxis, formulate the most efficacious pharmacologic combinations of antiemetics used for PONV prophylaxis, and formulate PONV prophylaxis algorithms and guidelines for adult surgical patients. For my QR project, I looked at if an educational module on the utilization of haloperidol as a pharmacological complement for PONV prophylaxis in adult surgical patients increases anesthesia provider knowledge and attitude in implementing haloperidol as an adjunct treatment in the management of PONV. Combination therapy incorporating haloperidol for PONV prophylaxis may contribute to a profound and positive transformation in the perioperative arena. Understanding the role of haloperidol in PONV prophylaxis may better equip anesthesia providers to combat the negative outcomes prompted by PONV and diminish the occurrence of PONV overall. Although the severity of PONV has decreased, the incidence has not. Despite the availability and use of current treatments, PONV still affects over 25 to 30% of surgical patients. The incidence of PONV has been found to be as high as 80%. In the adult population, the PONV incidence has been noted to be the highest at 40 to 77% after laparoscopic procedures. Otorhinolaryngological and ophthalmic procedures among adults have been tied to a 71% incidence of PONV, while intra-abdominal surgeries came in close at 70%. Additionally, gynecological surgeries ranked a PONV incidence of 58%, and breast surgeries were linked to a 50 to 65% PONV occurrence. Associated problems of PONV include esophageal rupture, wound dehiscence, aspiration, decreased oral intake, electrolyte disturbances, dehydration, bleeding, venous hypertension, and airway compromise. Various anesthetic, surgical, and patient factors help predict the potential incidence and severity of PONV. The International Anesthesia Research Society demonstrates a relative depiction of intraoperative and postoperative PONV risk factors amongst adults where the size of each segment is proportional to the odds ratios of PONV associated with each risk factor. Anesthetic risk factors depend on the utilization of volatile anesthetics, nitrous oxide, opioid administration, anesthetic duration, and anesthetic technique. Patients most at risk are those who have received inhalational anesthetics and opioids. General anesthetic technique has been found to cause more PONV than regional anesthesia. Despite the lower occurrence of PONV with a total intravenous anesthetic technique, PONV still occurs. Other notable PONV triggers are nitrous oxide use and longer anesthetic exposure. Surgeries linked to the highest PONV incidence are longer procedures, and those of gynecological, breast, ophthalmic, otorhinolaryngological, intra-abdominal, and laparoscopic nature, especially cholecystectomy. Specific to children, PONV risk is increased by strabismus surgery and procedures lasting longer than 30 minutes. Patient factors such as genetics, PONV history, gender, age, and smoking status also play a role in the incidence of PONV. The greatest PONV predictors in order of influence are female gender, previous PONV history, first-degree relatives with PONV history, non-smoking status, motion sickness history, and those who are younger than 50 years old. Specific to children, PONV risk is increased by age, greater than 3 years old, and PONV family history. Currently, many medications are available in the anesthesia provider's PONV prophylaxis drug armamentarium. Literature classifies PONV medications as older generation, newer generation, and non-traditional antiemetics. The newer generation antiemetics include serotonin receptor and NK1 receptor antagonists. Serotonin receptor antagonists are known for ligand binding and blocking the serotonin 5-HT3 receptor in the GI tract vagal afferents and the chemoreceptor trigger zone. The most used serotonin receptor antagonist is ondansetron. NK1 receptor antagonists block NK1 receptors in the peripheral nervous system, area postrema, and nucleus tractus solitarius, preventing substance P, the natural ligand, from binding. Examples include aprepitant, quesopitant, and rolapitant. Corticosteroids have been classified as non-traditional antiemetics. However, their mechanism of action in this respect is unknown. There is suspicion that the anti-inflammatory and endorphin-releasing properties of corticosteroids may contribute to their antiemetic effect. A commonly used corticosteroid is dexamethasone. Older generation antiemetics include phenothiazines, antihistamines, anticholinergics, benzamides, and butyrophenones. Phenothiazines are responsible for antagonizing dopamine D2 receptors in the chemoreceptor trigger zone. Examples include chlorpromazine, promethazine, prochlorperazine, and perfenazine. Antihistamines affect the nucleus of the solitary tract histamine H1 receptors and the vestibular apparatus by antagonizing acetylcholine receptors. Examples include diphenhydramine, dimenhydrinate, hydroxyzine, and cyclizine. Anticholinergics work on the pons and cerebral cortex, blocking cholinergic and muscarinic receptors in the central nervous system. Examples include scopolamine and atropine. Among the benzamides, metoclopramide is administered the most and is known for its prokinetic properties. Metoclopramide specifically antagonizes GI tract dopamine D2 receptors and affects the same receptors in the area postrema and the chemoreceptor trigger zone. Butyrophenones are recognized to work at the area postrema and the chemoreceptor trigger zone as dopamine D2 receptor antagonists. Examples include haloperidol and droperidol. According to Eberhardt et al., no single drug is credited with the power to diminish PONV to a tolerable level. The use of a sole agent for PONV prevention has been advised against due to the potential for better outcomes with a combination approach to PONV prophylaxis. Research advocates for the utilization of combination therapy for PONV prophylaxis with the understanding that antagonizing multiple receptors associated with PONV can provide superior PONV prevention in surgical patients. The International Anesthesia Research Society summarizes common combinations of antiemetics recommended for PONV pharmacologic combination therapy for adults and children. Although there is significant literature available today that addresses PONV, the utilization of PONV combination therapy in surgical patients is lacking in practice. De Winter et al. Published that there is limited knowledge of PONV guidelines and adherence to published guidelines is not consistent. The International Anesthesia Research Society expanded on previously published iterations on PONV prophylaxis recommendations and suggested guidelines in 2020 that modeled haloperidol's medication class in PONV combination therapy. The most recent PONV practice guideline update published by the International Anesthesia Research Society is endorsed by multiple international professional societies, including the American Society of Anesthesiologists and the American Association of Nurse Anesthesiology. Additional anesthesia experts supporting the PONV practice guidelines published by the International Anesthesia Research Society include the following societies: the American Society for Enhanced Recovery, the American Society of Health Systems Pharmacists, the American Society of Peri-Anesthesia Nurses, the American Academy of Anesthesiologist Assistants, the American College of Clinical Pharmacy, the American College of Clinical Pharmacy Perioperative Care Practice and Research Network, the Australian Society of Anesthetists, the Brazilian Society of Anesthesiology, and the Chinese Society of Anesthesiology. These guidelines suggest utilization of antiemetics based on risk stratification. For the International Anesthesia Research Society, the recommended guidelines for PONV management in adult surgical patients suggest administering 2 agents if exhibiting 1 to 2 risk factors for PONV and giving 3 to 4 agents if there are greater than 2 risk factors. The recommended prophylactic PONV agents highlighted for adult use by the most recent algorithm in 2020 are meant to be selected from different drug classes, which include the following: 5-HT3 receptor antagonists, antihistamines, corticosteroids, dopamine antagonists, NK1 receptor antagonists, and anticholinergics. Among children, the PONV prophylaxis guideline published by the International Anesthesia Research Society also involves risk stratification similar to that of adults, except recommended agents are 5-HT3 receptor antagonists and dexamethasone as depicted. In 2018, the British Journal of Anesthesia delineated a PONV algorithm that recommended using up to 3 antiemetics, droperidol, ondansetron, and dexamethasone in PONV prophylaxis depending on PONV risk stratification. This algorithm was later simplified based on gender. Haloperidol has been underutilized in anesthesia. However, droperidol provided a sufficient antiemetic treatment before it was labeled with a black box warning due to sudden cardiac death. Although haloperidol is not FDA approved specifically for PONV prevention, the black box warning placed on droperidol has led to its declined use, and there has been an increased interest in haloperidol utilization as an alternative. Even though suggested guidelines and algorithms exist, there is no gold standard combination PONV treatment, including haloperidol, that is being followed consistently to lower the PONV incidence below the current occurrence in all surgical patients. Extensive research highlights the value of haloperidol in PONV prophylaxis and combination PONV therapy. Haloperidol is labeled a typical neuroleptic that exhibits sedative and alpha-adrenergic inhibiting properties unlike atypical neuroleptics. The initial indications for use were for hallucinations, delirium, and psychomotor-related diseases. In 1975, the anti-nausea and antiemetic properties were first discovered. It first became known in 1976 to block dopamine receptors when inhibition of dopamine production on cyclic adenosine monophosphate occurred. Now it is classified as a butyrophenone that works at the area postrema and the chemoreceptor trigger zone as a dopamine D2 receptor antagonist. Optimal and efficacious dosages of parenteral haloperidol for PONV range from 0.5 mg to 2 mg. Among the suggested PONV prophylaxis drug combinations supported by the ASA, haloperidol is found to be a promising option when grouped with ondansetron and dexamethasone. According to the AANA publication by Smith and Wright in 2005, haloperidol's PONV prophylactic potency begins within 30 minutes of administration, and its duration of action is 4 hours. Yang et al. Explored the PONV prevention efficacy of haloperidol in 2008 and compared the timing of administration during the perioperative period in a randomized double-blind study of women undergoing plastic, gynecological, breast, and thyroid surgeries. Findings by Yang et al. In 2008 showed no difference in the antiemetic efficacy of haloperidol when administered at induction or 30 minutes prior to the termination of surgery, which was suspected due to haloperidol's long elimination half-life of 12 to 35 hours that typically averages 16 hours. Butyrophenones rarely cause extrapyramidal symptoms and have been associated with QT prolongation, torsades de pointes, hypotension, sedation, neuroleptic malignant syndrome, urinary retention, nightmares, and visual disturbance. According to Smith and Wright, haloperidol use was linked to the presentation of adverse effects previously mentioned when it was given at high doses in psychiatric practice, such as 35 mg or more, within a 24-hour period. At low doses used for PONV, the risk of adverse effects is minimal. Despite the low risk, it is best advised to avoid haloperidol in patients with QT prolongation, congestive heart failure, acute chronic dysrhythmias, electrolyte disturbances, cardiac hypertrophy, acute cardiac syndromes, Parkinson's disease, and neuroleptic malignant syndrome. Additionally, patients taking monoamine oxidase inhibitors and tricyclic antidepressants should refrain from taking haloperidol. In 2019, Dag et al. Sought to find the most effective dose of haloperidol as a sole agent that provided the least amount of side effects and yielded the best PONV prevention. Dag et al. Studied 250 female patients in a randomized controlled trial who were scheduled for laparoscopic abdominal hysterectomy, and it was found that the optimal and efficacious dosages of parenteral haloperidol for PONV range from 0.5 mg to 2 mg. At such low doses, no QT interval prolongation or arrhythmias were observed. Participants did not experience differing levels of sedation or variation of vitals at all doses. In 2008, Greco et al. Conducted a randomized double-blind trial that compared the PONV efficacy between combination therapy and a sole antiemetic agent among 268 general anesthesia or combined general anesthesia epidural patients. In this study, combination therapy with haloperidol and ondansetron provided a longer-lasting and efficacious PONV prophylaxis versus ondansetron without haloperidol. No significant difference among groups regarding incidence of serious dysrhythmias, QT prolongation, other toxicity, or sedation was reported. In 2009, Feng et al. Conducted a randomized double-blind study to determine PONV prevention with haloperidol and ondansetron in 210 patients undergoing elective laparoscopic cholecystectomy. Subjects who received both haloperidol and ondansetron suffered the lowest incidence of PONV and required less rescue analgesics or antiemetics. Statistically significant superior PONV prophylaxis was observed with combination therapy involving haloperidol plus ondansetron. No significant difference in QT prolongation, incidence of EPS, and sedation level among all groups was reported. In 2015, Zhu et al. Published a randomized double-blind dose-response and placebo-controlled study that focused on evaluating PONV efficacy with haloperidol in combination with dexamethasone among 150 female patients who had undergone gynecological laparoscopic surgery. It was found that the combination of dexamethasone with haloperidol was more effective in PONV prevention than dexamethasone as a sole agent. All groups did not show a significant difference in pain severity, and there were no cardiac or neurologic adverse effects reported. In 2012, Wang et al. Conducted a study on PONV related to patient-controlled analgesia on 135 female patients undergoing gynecological, abdominal, and orthopedic surgeries who were expected to receive morphine PCA. Subjects showed similar PONV prevention after receiving 5 mg of dexamethasone intravenously with 2 mg of haloperidol intramuscularly, or the combination of 5 mg of dexamethasone IV and 4 mg of ondansetron IV. Findings published by Wang et al. Demonstrated that sole treatment of PONV with 5 mg of dexamethasone IV was not as efficacious as combination therapy with haloperidol or ondansetron. There was not an increased incidence of sedation, EPS, or QT prolongation reported among subjects. In 2010, Chaparro et al. Also evaluated the efficacy of haloperidol and dexamethasone in PONV prophylaxis among 166 non-smoking women undergoing otorhinolaryngological or cosmetic surgery. It was reported that there was a lower incidence of nausea and vomiting among subjects receiving haloperidol and dexamethasone. No significant adverse effects, including EPS, were found among subjects who received haloperidol. In 2008, Chu et al. Explored the combined PONV prevention power of haloperidol and dexamethasone among 400 women undergoing laparoscopic-assisted vaginal hysterectomy. Subjects who received the combination of 2 mg of haloperidol and 5 mg of dexamethasone experienced superior PONV prophylaxis. There was no significant difference in the occurrence of EPS, QT interval changes, sedation, and pain intensity among all groups. In 2013, Benavides et al. Conducted a randomized, double-blinded trial on a total of 90 male and female laparoscopic sleeve gastrectomy patients, which aimed to evaluate the efficacy of haloperidol, dexamethasone, and ondansetron in combination therapy to prevent PONV and the need for rescue antiemetics. It was found that there was a lower PONV incidence in groups that utilized a combined PONV treatment approach, including haloperidol, ondansetron, and dexamethasone. The use of rescue antiemetics was also reduced in groups that received haloperidol, ondansetron, and dexamethasone. Although some participants commonly reported dizziness and headache, the adverse effects were minimal and not significantly focused on in this study due to lack of influence on primary results. Research demonstrates that PONV still negatively affects surgical patients despite the use of available antiemetic treatments. Combination PONV prophylaxis is modeled as a goal of perioperative care. With the British Journal of Anesthesia algorithm and guidelines suggested by the International Anesthesia Research Society, haloperidol's drug classification is featured as a prophylactic antiemetic that showcases its reasonable capacity for inclusion in anesthesia practice for PONV. Recent literature shows decreased incidence of PONV when haloperidol was administered in combination with other antiemetics, dexamethasone and ondansetron, and when haloperidol was used alone. All subjects receiving haloperidol for PONV prophylaxis in combination therapy or alone did not exhibit significant adverse effects, increased sedation level, or a greater pain medication requirement.